morning.
Good morning.
Well, first, thank you very much for the invitation and for the very kind introduction. I probably don't deserve the majority of it. And I would like to start by apologizing because I think that this lecture might be a little bit slightly different what you normally, what you would expect, and maybe what you also hear. But I'm very happy that I am able to share this with you. So if this is something that is not of interest to you, I'm very happy. You are very welcome to turn on your cell phones and we'll go from there. So, in essence, I would like to, I think that you are all probably very well aware that we are in a state of healthcare crisis in this country. And probably also more than in the U.S. But in the U.S. this is especially pronounced. I'm sure that you know that because I think it's almost impossible not to be on the receiving end of this, either as a patient, as a provider, even just by intuition and interaction with others. I think what is perhaps is a little bit less known what really are the causes of this, and we may not know all of them, but I would like to propose to you that there is the main problem is that our approach to the way we conduct research in general, in medicine, in healthcare, how we apply the results of those findings, into our diagnostic tools, into our therapeutic interventions. And the reason for that, I think, is that all these actions that I just mentioned, so our research, our diagnosis, our treatment, are based on averages. And this worked very well for a long period of time because we didn't have the capacity or abilities to deal with these complex problems. But I think we are now at the verge of when things can change. And I think this hopefully is going to be a little of a silver lining at the end of this perhaps very depressing lecture. This is the GDP of the United States, and it's essentially division into the main parts last year. As you can see, that this part here, the part which is basically in blue here, which is the healthcare, is a major part. It's almost 20%. It's a huge amount. We went some $1 trillion, and we definitely outstrip all the other or healthcare basically spending are larger than anything else, any other sector, certainly more than defense and certainly more than education. But that, one could say, maybe it's not a bad thing, to invest a lot of money into healthcare, and that maybe we have a better results. And you perhaps know this slide as well, but in essence what it shows is that this is the health expenditures in several countries, mostly European ones, but not only, and versus life expectancy. So basically how the life expenditure, how the expenditures for health correlate with the increase in life expectancy. And I think I like this picture because it's very clear. One could say a lot of different things and opinions and other things, but in essence it's clear that we are spending more and more and we are getting less and less in return at this life expectancy. I think what is especially concerning is that we essentially this curve is, since the 1970s, we are basically departing from the rest of the pack, from the other countries. We are spending more. And one could say that in probably the last 4, 5, 6 years, we are spending with essentially without any significant improvement in longevity. And this is also probably true for our things. So I would like to propose that this part here, this departure between how much we are spending and how much are spending people or countries that are in the middle of that pack, with basically countries with the same life expectancy of ours, is about 5 facts. So if you the countries with the same life expectancy as ours, at least in 2014, were spending approximately $2,000. We are spending almost $10,000 per person. And what is it? We could call it different things, but in essence, this is just a term I made up when we can say it's mobility-utilization. So we are spending money on things that are really not resulting in improvement of outcomes, which we hope that they are going to do that. And this is a big one, five-time increase in expenditures. It's substantial. What are the causes? This is it has been proposed that all leads essentially to, or is driven by three main things: the bias information, and I will propose that this is the issue with averages and individualization of care, conflict of interest, and defensive medicine. Bias information is, as I mentioned, our approach that we treat everybody the same, and essentially in our research, in our diagnosis, in our treatment, and we basically make a decision about diagnosis or treatment based on average findings. And we will dive into this a little bit more. The other two are the conflict of interest. We're living in a classic fee-for-service healthcare system. In essence, this is the system that incentivizes doing more diagnosing, doing more diagnostic tests, doing more treatments. And that's just by definition. I'm not saying that this is my opinion about it, this is how it is. And the second one is obviously defensive medicine. And this is a quote that I think puts it very succinctly and probably very well, that it's a suit for over-testing, over-diagnosing. There is, this comes also from publication from a group from Michael Lack Institute, where they get big answers and so people who do a lot of work, especially in this area. I'm just going to highlight those things because I think it's good to put these things in perspective, that there are other things than just our approach to doing practicing medicine and doing research in medicine. Defensive medicine, yes, these are very worrisome things. 7.4% of doctors get sued each year, and by age 65, vast majority of them, even in the sort of low risk from point of view of legal litigation, subspecialties, most of them get sued by the end of their career. But let's concentrate here on this biased information. And I would like to propose to you and try to make this argument to this talk, that this is all related to false positive findings, that this lack of individualization basically leads to the false positive findings, and they in turn lead to more tests, more interventions, and also to problems with reproducibility of our research findings. Do we really have a problem with individualization? I would say that this is another example that shows that we definitely have to individualize. Why? This is basically spending in the United States for healthcare in severely and non-individualized population in 2012. And I think this is something that perhaps is the very important part here. Most important. The top 5% of population, so 5% of the population is responsible for 50% of all the healthcare costs. Again, 5% is responsible for half of everything that has been spent. So obviously there's a subpopulation that is very high risk. This is data from Kaiser Permanente system, and basically showing in different ways the same thing, but actually very interestingly, again, they show that top 5% was responsible for 51% of all the health expenditures. I like this part as well. That there is, because it's not only about who is at the high risk, but it's also about that there are a lot of people who are at very low risk. So again, the lower 50%, so the people who are healthy, 50% of healthy people, on them we are spending only 3% of all the health expenditures. I think this puts it very, very clearly that there are groups of patients or group of people, because some of them are healthy, that are very low risk, and some of them that are very, very high risk. And this is the basis why an argument, a rationale, why should be individualized, at least one of them. The reason I put this here because it is, at least in my mind, is staggering how big those differences are. So, in essence, despite what you think, we are all very different. And I'm going to try to argue that at the moment, how different we are. We really don't really realize, how different it is here. And by the way, how I place those images has absolutely nothing to do. It's completely random. So that's something, this is essentially data from the large study we have done in the late 90s, about 38,000 patients, pregnant women who are doing it for screening, finding basically a new test for screening for Down syndrome. But I'm using it as basically just to show you something of which is my interest, and I think maybe of interest to you as well. So if among those women, if we show for the distribution, for example, of their age, the mean age was 30.1 years. And that women between 30 and 31 years constituted 2,412 out of the 37,000. So not very many were actually, proportionally about 6% were average age. Right? Here is the distribution of their heights. The average height was 164.4 centimeters. So if we just bend generously the mean somewhere between 163 and 165, so within about an inch, it was only 183 women out of 37,000 that were actually of that mean height. This is their mean weight, 67.7 kilograms. You can see this. This is not the normal distribution. It's skewed. If we, let's say we a little bit generous, about 2 pounds for a bin who is average weight, so 67 to 68 pounds. There were 771 women who were average weight in that group. And this is the birth weight of the babies. Birth weight was 344 grams. So the then for average, so between 340 and 350, there was 699 women out of 37,000. So, but I think this is the most interesting things. So I'm going to show you here this. So women of mean age, there was 6.4% of women that were mean age. There was only 0.03% of women who were of mean age and mean height. There was only one woman out of 37,000 who was of the mean age, mean height, and mean weight. And there was actually nobody who was mean age, mean height, mean weight, and mean birth weight. However, we had majority of the analysis that have been done, and not only for the study, I don't want to simulate the study, I just got the data that was easy to show. But for everything else is based on those averages. So we are essentially modeling and looking for something that doesn't exist. And I can tell you that it has been done many, many times before. The whole work began with the United States Air Force and trying to optimize the cockpits of planes and things like this, and they realized actually there's no average pilot. Everybody was uncomfortable because and don't know what the consequences of this were. And well, you can say, okay, so all right, so we are all different. We have somebody is a different height, but maybe it has a lower weight and other things. But what does it mean really for health, and what does it mean for medicine? And remember that this applies to all the characteristics. That includes the risk factors for diseases. It includes that determines the probability of having a disease, for example. Here's something that we have done in our study using the primary data, and we're trying to basically build a model that includes birth weight of the offspring to predict the risk of cardiovascular disease. I'm going to show quickly later on how that works. So basically, we're trying to build a model which includes the outcomes of pregnancy to improve prediction of a woman is going to have a cardiovascular disease. And basically, this is the risk of cardiovascular disease based on in those 419 women. The risk of having cardiovascular disease later on in life usually goes around 20 years down the road from the delivery. This did not include any of the birth weight. This is just classic Framingham Hart score. What you can see is that it's basically clear, right? This vast majority of people have very, very low risk. And there are few people with very high risk. Why? Because the distribution of this risk factor there in this score are varied. A lot of people don't have average risk. A lot of people have very low risk. If you would put average, it's going to be somewhere in the middle. But actually, the vast majority of them have lower one. So why is that? We can start wondering, all right, we are all different. We have different risk of disease. Most of us don't have very, very high risk of those things. Maybe have a high risk of something else. And then all points to individualization. But why is that happening? And the reason is that we are complex systems. Complex system essentially means three things. That it's made of a very large number of parts, that has a lot of connections. All those parts interact with each other, have interactions. And that those interactions, because of that they are bidirectional, create feedbacks, positive or negatives. It means the relationships are nonlinear. And I think anybody here who would try to work with this kind of system knows that this is very, very difficult problem. Very. Even for, with supercomputing, this is a very, very difficult problem. Because just even if we have, some engineering problems that in complex systems, they're very difficult to solve. Because the number of these possible interactions is increasing exponentially. And then that's in things like planes, space stations, this kind of things, the modeling of climate and for example, ice caps and things like this. But just imagine human body. Human body has 10 to the 14th power of cells, 10 to 26 or 7th power of molecules. Now the interactions are 2 to that number, or 2 to the 10th to the 14th power, and then they are non-linear. If you start thinking about it, then one can really realize, that it's humiliating and makes start wondering. Actually, I think brings it into very clearly to ask, why is it so difficult to do those things? So this is an example of a very, very tiny complex system. Just only to give you a little taste how this would look or visualize that essentially. So we have only about 100 of different elements that interact with each other, and they result in some outcomes. So we have 3 outcomes that are all together that are basically the 3 facets of the same outcome. Some kind of disease of your favorite one. So this part of this disease can be caused by those red lines here. By those can be through this pathway, positive pathway. This can be caused by this positive pathway. This one. This one is going to be caused by the other ones in red. And then, well, the result is basically a situation, which you can see here, that we have a complex system. Complex system basically, because of all these interactions, have two consequences. They have many others, but two main ones for us, for health, for medicine. One, there's no such thing as root cause. I know it's terrible. Waiting now for people to start going to tomatoes. And I know we always say, oh, what's the root cause? You look in media and look at TV, root cause of this, this cause that. Reality is there's no root cause. There are different causative pathways. In some people there is that, and somebody else is something different. They may be similar, but it's very unlikely there will be one. Why? Because there is so many possibilities that these things can happen through all these connections. And it would be very unlikely also from the evolutionary point of view that you will have one single thing. Because if it was, those individuals would not be our ancestors. They would have been eliminated by now, or a long time ago. The second consequence is that those systems, they have developed this way because they are very robust. Very rarely something breaks as you go. Why? Because again, you have so many alternative things. If something is broken, for example, here, well, you can go the other way around. And because of that, the outcomes, the bad things, they call them failures of the complex systems, are very rare. That's great for us, but it's very difficult to study. Studying rare events is very, very difficult. Just imagine, for example, one of the things we work on is maternal mortality. Maternal mortality happens about 20 times per 100,000. It's great. And we are very thankful that it's rare. But then how difficult it is to study something like that is so rare. So these are the consequences. And I am going to try to propose to you that this is the reason why we have problems with this attitude to analyzing data, the focus on averages, as the reason why we have problems with the reproducibility of our research findings. You may have seen this study done by John Ioannidis in 2005. He basically did something which was pretty ingenious, I think. He basically took 49 studies. I call them the golden studies of medicine. So basically studies that have been published in the best journals. 3 of them, I'm not going to say where because you can read it, but I think it doesn't matter. I think it applies. But anyway, one the best of the best. And one of the journals, JAMA, actually was, I have to say, impressively, they published the study themselves. So basically, he took 49 studies. They have been the gold standard of medical management. Each of them was published in the top impact fact journals, and has been cited at least 1,000 times. Each of them. So what happened first was, what is very interesting is that only 8 of those studies showed that there was no effect. So over 92% of those studies were showing positive effects of something, some treatment, successful effect of diagnostic tests, high accuracy, for example, most treatments. And then what happens to them? Then they basically look at studies that have confirmed subsequent studies that of the same size or larger and comparable quality. They have confirmed the finding of those gold standard studies. And what we found out basically is that about 16% could not be reproduced by subsequent bigger, larger or similar studies. And in 16% of those studies, the effect was much weaker than in the first one. So essentially, in 30% of a third of all this gold standard, the best of the best research could not be reproduced. And then he ran another study later basically showing that on theoretical grounds, this is not a surprise. This is not something that we should be surprised actually by, although we all were. I'm sure everybody else, and he basically distilled it into these 6 factors which affect why studies cannot be reproduced. And I think I will leave you to read this. I think it's very interesting. Again, I'm coming back here to this So this probability of cardiovascular disease in women, and basically showing that vast majority of people have a very small risk, here somewhere between 0 and 10% only. And why I'm showing it? Because we have a tendency, and we, including myself in this, anybody who researches health, practices medicine, has a tendency to approach it in a deterministic way. Deterministic meaning either this or that. You have it, you have a disease, you don't have a disease. You get it treated and you succeed or you don't. And or you should have this treatment versus not. Reality is it's much more complex. And I think William Osler probably said it really well. I really like this well. Medicine is a science of uncertainty and an art of probability. There's another quote, I don't remember who it is from, but I think it's also very good one, which says that we are struggling so much with uncertainty. Nobody wants to be uncertain. Everybody wants to know which way to go, because we are the deterministic beings living in the probabilistic universe. Why is that? Why we have so much problem? Because we are not able to calculate all those things. We are basically using heuristics, and heuristics are biased. Heuristics basically means subject to psychological biases. There's a number of them. This is no time to go into the detail, but I'm just going to tell you, just highlight one thing, which I see on daily basis, daily, or multiple times a day, and I'm sure the students can confirm this, or would confirm it. That what we overestimate probabilities of things that happened recently to us, or things that had an emotional impact. So, for example, if you are practicing low risk population, low risk setting, you have the feeling that nothing bad ever happens. Everybody's going to be fine, and no issues. If you are practicing with a high risk patients, for example, individuals, you automatically overestimate. So, for example, I do high risk obstetrics, molecular medicine, and I always have to kind of downgrade my first impression, and it's very difficult. That it's not everybody is going to die, not everybody is going to have a bad outcome, but actually the vast majority of patients are going to be completely fine. But we have a really difficult time overcoming this, and I'm sure if you give a thought to this yourself and think about things that how you estimate things that are happening to you in life, you are subject to the same thing. Because actually, this was developed in the 70s. This whole concept and confirmed by two statisticians, psychologists, Kahneman firstly, and they got the Nobel Prize in economics. Although there's actually no Nobel Prize. Baseline risks. The reason I'm putting this here is because we're going to move into some examples. And I think that's a very important thing to remember. Because this is all based on probabilities. Why is it based on probabilities? Because there is no perfect test or perfect intervention. There's no such thing that is 100%, this treatment, this pill works 100% of the time. It works, I don't want to say 90%, but probably doesn't work 90% of the time either. The same thing with tests. Then we don't have tests that are 100% sensitive and specific. It's probably impossible to have. We only can increase or decrease probabilities. However, we interpret those things, like they will be deterministic. And the first thing was Thomas Bayes who basically did this first based in statistics. But really, I think the whole theory was developed by Laplace, and should be precise. So this is going to be a few of those things, kind of the contingency tables, or confusion matrices you probably are familiar with. But and this is not to go in depth, and it's just to highlight things to give you a good for thought. So this is classic way of looking at diagnosis, right? We have people who have a positive test, and they have a disease or they don't have disease, that's called true positives, false positives, and people who have negative tests and they have either this disease or they don't have it. So and that's basically how it all looks like with true positives and true negatives, false positives, and false negatives. However, what happens if you change the baseline? So if there is very few people who have actually disease, so the true positives and false negatives are becoming small, right? And this part, false positives and true negatives, becoming large. And what's the effect of that? Let's say that we have something that happens 0.2% of the time in a population. So we have 30 people who have a disease, and about 10,000 out of 10,000 people. Make sense? Right? 30 out of 10,000. So that means that 9,970 people don't have a disease. That means that if you have a test that is sensitive 97%, which is as good as it gets in real life, then you have 29 people who have a true positive and one person who has a false negative finding. And these are the numbers for remaining, for specificity, let's say, of 99%. So out of 9,970 people without disease, only 100 people would be false positive. So that doesn't look that bad, but now let's look at what really matters. What matters is positive predictive value, right? What we want to know is if I have a positive test, what is the chance that actually I have the disease? So positive predictive value is 29 over 129, so 22%. What does it mean? That if you have a positive test, that means that you have 22% chance that you actually have a disease. And worse, it means that you have almost 80% chance that you don't have a disease. So if you have that test done, if this test, which is so good, 97% sensitive, 99% specific, if you do it in a population of patients who have a risk of 0.3%, that means that if you have a positive test, you can be fairly sure that you don't have the disease. Well, 80% chance, right? It's not so bad. So I just wanted to tell you that this, I didn't make it up. This is actually how HIV test performs in the low-risk population in the United States. So if you are in low-risk population and you get a HIV test, which is a very, very good test, if you have a positive result, you can be almost reassured that you're probably fine. And I'm not going to go through all these things, but basically it's very easy to show why it happens. Even with very high sensitivities and specificities, if the prevalence of disease is low, you are going to have a lot of patients who are going to be at a false discovery rate. And here I just put the numbers. When you would have a risk of disease of 1%, the chance of false discovery rate would be about 86%, similar to what we have done with the HIV testing. And one you could probably be wondering, is it true for treatment as well, for interventions? Well, this is basically how well the development of medications is doing. So in essence, I think that from this whole thing, the important part is here. So from the medications that are being introduced, so studies are being done on them, only 3% from the preclinical ones, only 3% actually end up to be approved by FDA in use in clinical practice. So basically, we could say that out of 100 tests that have been done, 100 studies, 3 actually are going to only make it, so 3 are going to be actually useful. Everything else is going to be not useful at all. Although they made it into the preclinical trials. So, and this basically is also a series of studies which show that even if we would go to 10%, so we are tripling the chance that something is actually true, that medication is really effective, for example, we can find out that with standard way we deal with these things. So basically, assuming that the power of the studies are 80% and P or false positives are 5%, 36% of the studies are going to be false positives. Interesting, because remember I showed you the study from the Ioannidis, which showed that 32% couldn't be reproduced. So there is, this is not a fluke. This is not something that just happened. I think it's actually built into the way we do this. All right, baseline risks, and I'm not going to bore you with this kind of things, but in essence, what I'm trying to show in these studies is that even if you would have this is kind of a simulation essentially, if you will have a perfect test, 99% sensitive and specific, if you apply it to low-risk population, I'm going to get to a logarithmic scale here, the vast majority of if you have a rare outcome, for example, something that happens 1% or less, but the majority of the diagnostic tests are going to be less than 50%. There can be more than 50% false positive. And there's a problem for people who are, like myself, studying rare outcomes. So for example, stillbirth will be here. Neonatal mortality, maternal mortality. Maternal mortality, even if you will find a test that is 99% sensitive and specific to predict it, the 97% of those positive tests will be false positive, just because it's so rare. And it's much worse, obviously, if you have tests that is more realistic, like with 70% sensitive and specific, then essentially almost all the tests are going to be 99% false positive. So what I'm trying to say is basically the things that the same thing is also for treatment. That it is important for us to study and try to identify new diagnostic tests, new therapeutic interventions. But even if we find something nearly perfect, it's still, if it's applied to population that is a low risk, general population, unselected ones, we don't individualize those tests or those interventions. The vast majority are going to be not useful. Worse, so this is a test that is 99% effective, so relative risk reduction is 99%. If we assume that every intervention has a harm, that we have a harm of 1%, suddenly the vast majority of people have not only don't have the benefit, but they have harm. Because most of them are low risk. Most of them are getting intervention that doesn't help them. And 1% of them is going to have a harm. And that obviously was putting here stillbirth, neonatal death, and then maternal mortality, just to show you that even if we would have this wonderful treatment, if we don't individualize patients, they are completely useless. They will just deliver harm without benefit. And then kind of a little, another way to look at the same issue. If we have, for example, randomized trials, and this is also another view at why we may have so much problems with our evidence, is if we have something that works, that reduces the risk of disease, a treatment that basically halves the risk of disease, so something that works, cures 50% of people, in other words. If we apply it for people who are of average risk, this is average here, by the way, but this is distribution of risk of the disease, so majority of people are going to be low risk, few people are going to be very high risk. This is the average, this is median. If you have average, if you apply averages to this analysis, and so average was 9%, we reduced it by 50%, so it's 4.5. And if you apply it to median, the median was 4%, we reduced it to 2%. The result is going to be that the mean, the comparison of means is going to be significant, and comparison of medians is not. Same reduction, same population, it just depends who we are going to use. And this is something I'm not sure you're going to like it, but it's another facet, another view why individualization is important. There's very few studies that have been done when doctors went on strikes. It's actually 7, this study. All of them have shown that either the mortality during that time decreased or was unchanged. Right? Practicing position. So we can wonder what happens, you know. So the first reaction is, oh, wow, they're killing people. But remember that, you know, if you have doctors go on strike, you know, even regardless what country it is, you know, it was Spain, Croatia, Israel, some from the 70s in Los Angeles. That does not mean that nobody gets treated, right? People don't die on the streets. What happens is that you are running a very, very basic service. So only emergencies get treated. You don't do elective things. What does it mean? You're only treating the high-risk people. And you don't treat these people who are maybe lower risk or maybe medium. And then just to finalize, this is a few things that we worked on over the years on individualization. Although at that time, actually, to be honest with you, I didn't even have that concept well formulated in my mind. This is a study when we looked at screening for Down syndrome, and basically found out, that based on patients' age and their hormone levels, we can determine how high risk they are. And again, vast majority are low risk. Very, very few people are high risk. This was about risk factors for stillbirth. And again, the same thing came out of this thing was that, yes, there are some things that are strongly associated with stillbirth. For example, diabetes, hypertension, lupus, and other things, but they're very rare. So, and then there are things that are very, that are associated with stillbirth that are like nulliparity, so basically somebody that didn't deliver a baby before it was the first baby. But that's half of all women. So that really doesn't help either. So it's very important to individualize, but it's not simple, and it requires a very complex approach. This was we individualized estimates of birth weights, and this is how we looked at prediction of ischemic heart disease based on if the baby was small for gestation. And so basically what we found out was that if mom gave birth to the baby that was small, she had increased risk of having ischemic heart disease for approximately 30 years down the road on average from the delivery. And that was independent of the classical risk factors for ischemic heart disease, smoking, diabetes, and other things. The advantage of this was that you have this information 30 years before you actually have a heart attack, not when you already have one, or quickly before that, 5 to 10 years later, in the case of cholesterol. And this was the same was actually was true for looking at women. This is some Framingham data, increased risk of cardiovascular disease, so basically stroke, heart attack, and AIDS. And then on the other end of the spectrum was we found out that women who have delivered babies who are large have increased risk of breast cancer about 2.7 times. As you can see, also many years later, age. And again, it was independent of the classical risk factors. We actually found out that when we looked at the profile of the hormones in women who had a large baby, that during pregnancy they were exposed to high levels of estrogens and high levels of anabolic estrogens and high levels of IGMs, which are growth factors and non-risk factors for breast cancer. And then just a couple of things that we're doing at the moment along this line. This is a study that we are starting with some NSF funding, basically trying to identify different things that will help us to individualize care in pregnancy, which is essentially collecting information from all these wonderful devices that all of you have here. And you might be surprised, or probably you're not, that these devices are collecting a lot of information on you all the time without you actually doing anything about it. So one of the advantages is the passive monitoring location of people who participate don't have to do anything about it. It's more objective because of that. It's basically creating an app, in essence, that collects the information from other apps. So, for example, how many steps you have done, what was your GPS location during the time when you were pregnant, and how did it change? Did you talk a lot on the phone? If you made mistakes, you were texting. All these things are actually shown to be harbingers of something deteriorating and psychology. I think psychiatry did a lot of work in this area. And what we are hoping to do is to basically find out the things that perhaps will say, okay, something is not right. Your routine, your normal behavior changed. Perhaps it would be worthwhile to have a look, what's going on before you even realize yourself. So that's one of the things, and we are using, this is all in collaboration with our group. This is made of people with joint appointment with Texas Advanced Computing Center. Now, since they received, I think, the largest NSF grant for supercomputing, I think it's going to be the largest supercomputer in the so-called open, meaning that people who like us can actually access it in the world. I'm sure the Department of Defense was better ones. But that's essentially where the analysis is going to be done. We are doing, this is something that was submitted, and we didn't receive that information if this is going to go or not. But this is essentially kind of doing an individualized monitoring of women during labor, doing two things. One, having a prior information, a person like this is how likely she is to have a problem during labor. And if she has, then we'll interpret the monitoring based on that prior probability. So basically it's Bayesian approach, prior, individualized prior, and then likelihood from the measurements. And measurements, this is the second coolest part, the so-called e-tattoos. They are this ultra thin, like this disposable tattoos. They're made just of gold, and they can measure things like blood pressure, pulse, and hydration, and EMG, but we are just basically using this as a proof of concept that this can be used, and if it can be used, then perhaps in another study. The main part of it is to see if we can individualize the approach to this vision. And obviously, we started doing it in Austin. That's tattoos in Austin. You can't go wrong with that. Then we have individualization of optimal time of delivery. What we found out that actually even low-risk patients, we found out that the optimal time of delivery, meaning time when the risk of stillbirth, individual risk of stillbirth, and individual risk of neonatal death, so death of the baby before birth or after birth is minimized. This time when it's minimized varies by almost 5 weeks, 4.5 in low-risk patients, depending on the number of variables. And then I would like to leave you with this thing, which basically means that this quote, it is exceedingly difficult to make prediction because it's all about prediction. Who is at low risk, high risk. And it's very difficult to do it. So Niels Bohr, I think the first person who said it was actually Israel. Prime Minister. That's very good. Thank you very much, and happy to answer the questions after.